Well, good morning, everybody, and thanks for joining us today. I'm just so glad to see you all. And for the people who are not on video, I'm awfully glad you're here too. On behalf of the Senior Adult Council, I'm delighted to welcome Dr. Richard Allman to address ethical allocation of scarce medical resources during a pandemic. I know that's a mouthful, but it's obviously a critical issue, especially as COVID-19 incidence, morbidity, and mortality continue to increase. Rich is going to talk to us about fair and equitable allocation of limited resources like critical care beds, ventilators, and medications, as well as vaccines. What we owe to low income and ethnic and racial minorities who bear a disproportionate burden of COVID illness, and how our faith relates to these issues. I know a lot of you know Rich and his wife Suzanne as active members of Bryn Mawr Presbyterian Church. Currently, Rich is serving on session, and he's also on the Church Regathering Task Force, which is giving us guidance as to when we'll be able to convene again. Rich is a graduate of Thomas Jefferson Medical College. He was an internal medicine resident at Allentown Hospital and a rheumatology fellow at Boston University and Temple University hospitals. Rich has practiced many years at Philadelphia's Einstein Medical Center, where he has served as chairman of the Division of Rheumatology, as well as president of Einstein's medical staff. In addition to this and his teaching at Jefferson Medical College, Rich is a medical ethicist. He holds a master's degree in healthcare ethics from Creighton University and has served as chairman of the Moss Rehab Ethics Committee, a member of the Einstein Institutional Ethics Committee, and an affiliate scholar at the Georgetown University Medical School Center for Clinical Bioethics. Currently, Rich is serving on the Pennsylvania Health Department's Ethical Allocation Committee, which is developing a framework for equitable distribution of scarce COVID-19 treatment and preventive care across the street. Clearly, he's got a lot to share with us. And Rich, thank you so much for being here.
Thank you, Pam. And welcome, everybody. I was quickly looking through the list of participants, see if there's any troublemakers here, and I'm relieved to see there are none. So for the next 40 to 45 minutes, I'm going to try and cover a lot of ground, and we'll see how successful I am with this. I'm going to talk about the whole issue of COVID, what it is, who's been affected, what the consequences have been, what some of the management strategies are at the present time, something about vaccines, what kind of vaccines they are, issues about availability and logistics of distribution, and then allocation of healthcare resources in general, which has to do with scarce resources. I'll say something about what is not ethically defensible allocation of resources. I'll talk a little bit about our Pennsylvania process for vaccine allocation, mention some of the contentious issues in vaccine distribution, talk about some of the unique problems in special populations, how allocation is applied, something about scarcity, what do we owe those who are denied scarce allocations, and a response to COVID looking through the lens of Christian moral theology. So it's an ambitious task I've set myself, and we'll decide whether or not I met the challenge at the end. The problem of COVID-19, the incidence, as we know, there have been more than 22 million cases so far in the United States, with over 400,000 deaths to this point. There have been about 17,000 deaths in Pennsylvania. The social economic toll has been enormous. There's no consensus about preventive measures such as masks, social distancing, who's an expert, what counts as effective treatment, or the magnitude of the problem. And what should be commonly accepted public health measures have been overly politicized. David Fidler is an adjunct senior fellow at the Council for Foreign Relations, and this is a quote from something he published in Science several months ago. Domestically, the extent to which governments have ignored science, denigrated health experts, supported quack remedies and policies, peddled disinformation, and botched social distancing and other non-pharmacologic interventions has been astonishing. This travesty flows from the traction that populist, nationalist, anti-globalist, and authoritarian attitudes have gained around the world. This is where we live our lives at the present time because of the physical isolation that's been imposed upon us by this. A year ago, I didn't know what Skype and Zoom are, and now they're our lifeline to the outside world. The center of this is Agnes, not because any of this is her fault, but this is a screenshot from our church's webpage, and just to illustrate that even as a congregation, our worship is now remote. I know that we are a pluralistic community and we're a pluralistic congregation, so tastes vary as to what news sources people resort to during these times. There's probably a consensus that Netflix and Prime Video are very important parts of our lives. And if there's time at the end and anyone has any questions, if other streaming services I could mention to you. This is just a summary of what COVID's all about. About 81%, 4 out of 5 patients who develop COVID will have rather mild symptoms, either a mild pneumonia or upper respiratory type illness. But about 14%, 1 in 6, will have rather severe illness with shortness of breath, low oxygen levels in their blood, and significant involvement on imaging of their chest x-rays or chest CT scans within 24 to 48 hours of onset of their illness. And then about 5% of people who develop COVID will develop severe disease with respiratory failure, possibly involving mechanical ventilation, shock, inability to perfuse vital organs, or multi-organ dysfunction. The overall case fatality rate has been about 2.3%, and it's pretty much confined to those with severe disease or critical illness. This is, however, much higher than you would expect to see in seasonal flu. The symptoms of COVID are rather nonspecific. Cough and fever are the most common, but people may have muscle aches, headache, shortness of breath, either new or worse than baseline, sore throat, diarrhea, nausea, vomiting, disorders of sense or smell, sense of taste, rhinorrhea, which is a fancy word for runny nose, or nasal congestion, chills, fatigue, confusion, chest pain, or pressure. So it's a pretty broad group of symptoms that will raise the suspicion for COVID, though suspicion's clearly heightened during a pandemic. This is a busy slide just to point out that there are testing things which are available. If you go to the drive-through window at Rite Aid or CVS, they will probably do a nasal swab or a throat swab looking for an antigen, and the turnaround time for that test is about 1 hour. It's sensitive most typically in people who have symptoms, and usually within the first 5 to 7 days of symptoms. There are other tests for current infections, such as some nucleic acid based tests. They're variable in their reliability. They will have false negatives, which means that the test will be negative even though someone has the illness. And how quickly they can be turned around really depends on the workflow of the laboratory. And then there are serology tests where they will draw blood and test for antibodies. And that's most useful for diagnosis either of prior infection or ongoing chronic infection. There are some factors which will predispose people to worse outcomes with COVID, and that is other comorbidities or pre-existing conditions, which will predict a worse and more severe outcome. People who have underlying cancer, those who have chronic kidney disease, chronic obstructive lung disease, who are immunocompromised from medications following a solid organ transplant, such as a heart, lung, kidney, or liver, obesity, pregnancy, and there's a risk there not only to the pregnant woman, but also to her fetus. Those who have serious underlying heart disease, either heart failure, coronary artery disease, or disorders of the heart muscle, sickle cell disease, those who are cigarette smokers, type 2 diabetics, any of those can be predicted to have a worse outcome. And there's some possible risk factors as well. Those who are asthmatic, who have had strokes, cystic fibrosis, high blood pressure, who are immunocompromised either from bone marrow transplants, HIV, or use of medications that suppress immune response, such as corticosteroids or other immunosuppressives, things that parenthetically I prescribe every day in rheumatology. Those with liver disease, neurologic conditions, who are overweight, who have pulmonary fibrosis or scarring of the lungs, thalassemia, a blood disorder seen typically in Mediterranean populations, and type 1 diabetes. Also, some demographic predispositions to a worse outcome. Those who are 65 years or older, or those who are 55 and older who have coexistent cardiovascular disease, high blood pressure, or COPD. Complications of COVID, respiratory failure requiring mechanical ventilation, cardiac abnormalities, including heart failure, shock, heart rhythm disturbances, thromboembolic complications, such as stroke or pulmonary thromboembolism, blood clots to the lung, various neurologic disorders, seizures, cognitive deficits, gait disturbances, and severe inflammatory disorders, which sounds mysterious, but it's a terrible thing, trust me. Males have a disproportionately higher number of critical cases and deaths, and that's looking in multiple populations. And in the United States and the UK, Black, Hispanic, and South Asian individuals have more infections and worse outcomes, not so much because of any genetic predisposition as because of coexistent disparities in social determinants of health, housing, food safety, all of the things that result in various distributive social injustices. The treatments for COVID are largely supportive, although we've gotten better at it from the sheer volume of cases that have been seen. There's no silver bullet, there's no specific antiviral which is available, but there are things that are done that help patients, treating coexistent bacterial pneumonia or flu, managing fluids or electrolytes, the circulating minerals in the blood, sodium, potassium, chloride, calcium, magnesium, follow the oxygen levels and supplementation if necessary. Low dose dexamethasone, please no one ask me questions about the dose, that's beyond the scope of our presentation this morning. Monoclonal antibodies, which may prevent progression to more severe disease. Remdesivir, which is a weak antiviral that has been shown to shorten the course of hospitalization for patients. And then some specific anti-inflammatory agents, anti-IL-6 medications such as Actemra, JAK inhibitors, things like Xeljanz, things that we use in rheumatology that may be useful in overwhelming inflammatory disorder. And then nursing measures such as positioning patients properly to allow drainage of respiratory secretions and clarifying the goals of care with patients and their family. Anticipate thromboembolic, neurologic, or cardiovascular complications, and supportive care for patients and families of patients who will not survive. Things that are not particularly useful are hydroxychloroquine and Clorox. If you think that once COVID is over, that's the end of the story, regrettably, that's not the case. Many patients, as you can see, up to 87% in some series will have long-standing fatigue. And anyone who's ever suffered from severe fatigue can tell you it's every bit as unpleasant an experience as pain. Persistent shortness of breath, chest discomfort, cough, loss of sense of smell. Less commonly, people may have joint pains, headache, dry eyes, dry mouth, runny nose, absence of sense of taste, poor appetite, dizziness, vertigo, muscle aches, hair loss, sweating, diarrhea. It sounds awful because it is awful. And then there are some long-lasting psychologic or neurocognitive disorders, post-traumatic stress disorder. And why why would you think that's not the case, given that people may have ended up with sustained periods of mechanical ventilation, memory deficits, difficulty with concentration, anxiety and depression, and overall reduced quality of life? Vaccines are the hot topic at the moment, and they come in a number of flavors. There are vaccines which are directed against an inactivated virus, where the virus has been killed but still has the properties that allow the immune system to recognize it in a recipient and develop immunity to the virus. There are live attenuated viruses where the virus is still alive, but it's basically been kneecapped and still has a somewhat more robust and sustained immune response when given. There are recombinant vaccines where recombinant technology produces a particular piece of the virus called the spike protein, which the immune system recognizes as the virus and directs a response against the virus. There are vector vaccines where you use an innocuous vector into which the spike protein or a piece of nucleic acid has been inserted, and the virus basically is a missile, and that which you put into it, the spike protein or something else to stimulate the immune response, is the payload. The problem with this is that the reason that these viruses are innocuous is we have widespread immune response to it. So the virus itself may be destroyed before it gets to parts of the body which can develop the immune response. There are DNA-based viruses where a piece of DNA is injected to direct the recipient's body to produce an immunologic target. You use DNA viruses, you're messing big time with Mother Nature because you may change the genetic makeup of the recipient. And RNA viruses, which are widely used at the present time, assigns one task by putting a piece of RNA into the recipient cells to produce the target protein. The other advantage to the RNA viruses is they can be produced rather cheaply. And the two current products which are available, the Pfizer and the Moderna, are RNA-based viruses, which are given as 2 doses separated by 3 weeks in the case of the Pfizer vaccine, or 4 weeks in the case of the Moderna vaccine. Soon there will be a single dose vaccine available from Janssen, also an RNA-based technology. This is just a graphic representation of what I said, where a piece of RNA or DNA can be put in some kind of a lipid envelope, injected, delivered to cells that will produce a target for the immune system in the recipient. On the upper right are the viral vector viruses, an innocuous virus which has a payload put into it to be delivered to cells that will do the same thing. There are subunit viruses where a subunit, which is a robust immunologic target, is introduced. The problem with that is purification, because there is a danger that a live active COVID-19 virus could contaminate those. And then the weakened or inactivated viruses, either a killed virus such as the gray critter down there on the lower right, or the green one, which is a live virus that just isn't feeling too well, that can also stimulate an immune response. What do we want a vaccine to accomplish? Obviously, we want it to prevent infection. But if someone gets infected, we don't want that infection to proceed to a symptomatic infection. But if it does proceed to a symptomatic infection, we'd like for the vaccine to prevent the recipient from ending up in the hospital. Or if the recipient ends up in the hospital, we would like for that person not to end up in a critical care unit. Or if that happens, we'd like to prevent death of the patient. And most importantly, we want to prevent transmission of the virus through the wider community. So what can immunization accomplish? Prevent disease and mortality, particularly in older patients, those who have significant coexistent medical problems, who have worse outcomes, to minimize the pandemic's effect on the social infrastructure and economy, and to narrow unjust health inequalities, recognizing that the moral foundation of public health is social justice. Also, that minorities have worse outcomes and more comorbidities, and to reduce inequalities faced by systemically disadvantaged populations. Some questions that are out there: will the vaccine protect against severe disease, mortality, particularly in the most vulnerable? The answer to that appears to be yes. The vaccines which are currently available are estimated to be 94% effective. Is widespread distribution possible? We hope so, though so far it's an unanswered question. Other questions: can immunizing children diminish their risk of transmitting to vulnerable populations? Our senior adult population, our senior adult group, which is gathered here today, are very much missing their kids and grandkids because of this very question. Kids who are infected have higher viral loads even than acutely ill adults. But before we can even go there with vaccinating kids, at this point, there's no data whether or not vaccine is safe for children. What about if the side effects for the vaccine in older adults were severe? Well, that hasn't been the case, but we would have needed a different strategy were it so. Or what if the vaccine was less effective in older adults? In that case, the strategy would need to be immunize those who come in contact with older adults and protect them, and in the meanwhile, maintain stay in place and physical isolation protocols. This is what the group, the Advisory Committee on Immunization Practices, ACIP, which was appointed by the Centers for Disease Control, came up with as a priority list for vaccine administration. The ACIP is broadly representative. It included people from the fields of public health, epidemiology, infectious disease, vaccinology, geriatrics, primary care, the pharmaceutical industry, a broad-based group of experts. And phase 1A, which is 21 million people, is healthcare personnel. That sounds like a lot of people, but remember, healthcare is approximately 1/6 of our economy. It's a discussion for another time or place, whether that's the right amount, too much, too little of our economy focused on healthcare, but there it is. Then there are 3 million people who are residents of long-term care facilities. These are the highest priority. The healthcare population, in order to preserve the system and not have those of us in healthcare also become vectors of illness when we're exposed in the care of patients, transmitting it to other people. And then 1B, once 1A is completed or near complete, because there will be some overlap as vaccine becomes more available. Those over 75 years of age, 19 million of us. Frontline healthcare workers and or frontline workers in general, those who are first responders, work in food and agriculture, manufacturing, corrections, 30 million people there. And if you look at that, most of those people are people who are unable to work from home. They have to be out there on the front lines, and overrepresented in that group are disadvantaged minorities. Then 1C after 1B is complete or near complete are those who are between the ages of 65 and 74, what's been referred to as the young old, 28 million of them. And then individuals between 16 and 64, those who have high risk medical conditions, which we talked about earlier, 81 million people. And then those who work in other essential fields. And you can see the list there, transportation, finance, information technology, energy, legal, media, public safety engineers. Not all, but many of these people are able to work from home or remotely. So their acute need for prompt vaccination is not as compelling as in the 1A or 1B group. And then group 2 will be everyone else, 86 million people, those between 16 to 64. As I said, there has not been testing on the vaccine for safety or efficacy in those under the age of 16. Our Pennsylvania Vaccine Crisis Committee includes the State Secretary of Health. There's a group of physicians who are part of it, those in infectious disease, critical care, clinical ethicists, representatives of the governor's office, representatives of community health centers, emergency preparedness and management experts, people from epidemiology, vaccine scientists, the National Guard representing public safety, the retail pharmacy industry, nursing, long-term care representatives, Veterans Affairs. I would point out that the city of Philadelphia has a different funding stream and a separate plan from the other counties in the state. This is the Pennsylvania plan, and I'm not going to read the whole thing. I can't think of things that would be much more boring than reading lists of things to an audience. But what makes the plan, I think, particularly defensible is not how unique it is, but how much it conforms to the ACIP plan. But there's a little more specificity there because it talks about who counts as a healthcare worker. And it's not only physicians and nurses, but people in dentistry, podiatrists, people in private offices, and also all of our support staff, the people who clean patients' rooms, bring food to patients' rooms. So that's group 1A and the long-term care facility residents. 1B is much like it was described in the ACIP recommendation, but specifically the Pennsylvania plan says that 1B also includes those in congregate settings not otherwise specified as long-term care. This means incarcerated individuals as well. And there was some controversy with that. Phase 1C is the same as 1C in the other graphic that I showed you. But again, the takeaway point with this are, for the most part, though not complete, for the most part, these are people who can work from home. And then phase 2 is everyone else who's eligible. There's some unanswered questions and special issues surrounding vaccine access. What about children? At this point, the answer is no until there's further testing. What about pregnant women? There has not been significant testing in pregnant women, even though they have a worse outcome. What about those who say, I want a specific product? I don't want the Pfizer vaccine, I want the Moderna. Or at this point, it's been managed somewhat the way my mother managed dinner. Take what we give you and be happy you have anything. But as far as we know, that's not going to change anytime soon. What about an administration fee? Because the staff who is giving it, the supplies that are used are not free. And if it's going to be distributed through retail pharmacies, they're going to want some reimbursement for that. What about if there are changing priorities as scientific evidence evolves, if some demographics have unanticipated complications or a lesser response to the vaccine? Should homeless persons, migrant workers, psychiatric patients with unstable lifestyles and living conditions be prioritized to receive single-dose vaccine? I'm asking that rhetorically because I believe the answer to that is a loud yes, because those who can't be depended upon to return for their second dose, we still want to protect them. When can immunized persons return to a new normal? I wish I could answer that for you. And when can society return to a new normal? Same response. Vaccine refusal or reluctance has been a huge issue during the initial rollout. In our hospital, the non-professional staff, approximately 30 to 40% of them are refusing vaccines. And this is particularly disturbing because many of them are members of disadvantaged populations who are predisposed to a worse outcome from COVID-19 infection. And it's also turned out that in long-term care facilities, there's been an approximately 30% refusal of vaccine. I'll wait till next year. I'll wait to see what happens. This was announced on Wednesday at our meeting of the Vaccine Crisis Committee. And vaccine nationalism, I'll talk about that in a moment. As far as how the decision was made broadly for vaccine distribution, prioritized by life cycle to make sure that everyone has a chance to live through the various times of the life cycle. But will that impact on disease prevention and overall mortality? It also doesn't necessarily address healthcare disparities. It does address broad economic issues, since if we say we want to protect years of life, younger persons are those more likely to be employed. Instrumental value, healthcare workers, fire department workers, emergency services, police, food service, essential airport personnel. These are potential spreaders of the disease if they become infected, and they're also essential for the functioning of our society. So where we ended up is developing systems which prioritize a combination of things: those most predisposed to severe illness from COVID, those over 65, those with comorbidities, those who provide instrumental value and are at the highest risk of spreading the disease, appears to be the most prudent approach. Vaccine nationalism, American vaccines for Americans. These three values are important in considering how vaccines should be distributed internationally. We really want to benefit people by offering them vaccines and limit harm, prioritizing the disadvantaged, which is a fundamental value in ethics and global health, not discriminating on the basis of morally irrelevant differences such as sex, race, religion, and equal moral concern for everyone, irrespective of where on the planet they happen to live. Other reasons to reject the idea of vaccine nationalism is that research and development have been transnational. These companies are global multinational corporations, and if you don't think that's the case, check with it at tax time and the way they respond in their tax liability. And then global, we depend on global sources for supplies of things like vials, syringes, and other mundane things, gauze pads, Band-Aids, that we use in administering vaccines. This is based on some work that Dr. Emanuel at the University of Pennsylvania and some of his collaborators did, looking at why we need to be fair in global distribution of the vaccine, because COVID-19 kills people and causes permanent organ damage. So the goal should be to prevent deaths, particularly premature deaths. The pandemic indirectly harms health, even for those infected, uninfected, by straining healthcare systems, raising mortality rates for common conditions, which often cannot be treated because of stress on the system from COVID patients, causing stress that harms mental health, and accelerating the spread of disease by hindering immunizations for other disorders. The pandemic has devastated the global economy, causing unemployment, economic decline, poverty, and starvation. Economics and health interact with each other, with worsening economic conditions harming health. The worsening pandemic has hurt the economy, and the goal is to reduce serious economic and social deprivations. This is a table I'm just going to mention briefly from that same article by Dr. Emanuel and his group about fair global distribution of vaccine, with the goals being to reduce premature deaths, to reduce serious economic and social deprivations, and insofar as possible and as quickly as possible to return societies to full functioning. What about logistics of COVID vaccine? Distribution. This has been a problem. And as Secretary Levine said at her last meeting with us, since she's leaving to join the Department of HHS, as she mentioned this past Wednesday and every Wednesday, you cannot give the doses that have not been provided. The mode of distribution. It's easy for healthcare workers, although, as I said, there's been surprising resistance encountered. Those of us who are hospital or healthcare network employees just show up in the hospital auditorium at the specified time. The same applies to senior living facilities and nursing homes. It's easy to schedule a COVID vaccine program. But what about non-hospital based healthcare employees, private physicians, dentists, healthcare workers, home health aides? The logistics of that are more challenging. I know that our hospital has made a policy to set aside 10% of doses for those physicians, dentists, other healthcare workers in the community who are not directly affiliated with our institution and are not on our institution's payroll. After those in those structured settings are vaccinated, how about everyone else and how's it going to be done? And if you've looked at the websites and tried to make an appointment for a vaccine, you know what I'm talking about. Are there going to be mass county vaccination sites? Well, I believe Montgomery is in the process of establishing one. Will it be by appointment? Is it going to be in retail pharmacies? Will it be in faith communities like is done with flu vaccine? Well, the answer to that appears to be no, because we are physically isolated at this time. Here are some things that should not enter into the calculus of allocation and prioritization for vaccines or for anything else. One's net worth, one's perceived social worth or social position. This doesn't have to do with instrumental value, but having the right pedigree, being well-born, belonging to the right clubs. Whether or not one is a citizen, one is equally vulnerable to infection and to spreading infection. Ethnicity, religion, sexual orientation, disability, incarceration, whether or not one is a psychiatric patient, has a developmental disability, political conviction, age, unless it's a marker for enhanced risk, gender, those patients who are described as the dirty, the discourteous, the social misfits, no reason they should not be getting vaccines like anyone else. And I mentioned vaccine nationalism. Let's turn to a more broad look at rationing of healthcare resources, particularly critical healthcare resources during an emergency. How can we do this in an ethically defensible manner? The first step would be all means short of rationing must have been exhausted before resorting to rationing. And among the things during the pandemic, this would include transfer of patients to a facility that has the capacity to accept additional patients. Expansion of capacity. Probably the best noted one in the Philadelphia area was at Temple University, where they used the floor of the Liacoris Center, where usually the Temple Owls play basketball, as an overflow hospital. New York City used the floor of Madison Square Garden. Innovations, Italian critical care physicians during the worst of their COVID pandemic last spring developed an innovative means of taking two patients with similar body builds and sharing a ventilator by special design of the tubing to the ventilator from the patient. Clarification of advanced directives to be certain that the patients who are receiving critical care, that's really what they want. The rationing process must be public with broad-based input. There can be no covert rationing. I know our Pennsylvania process included people from critical care, infectious disease, epidemiology, hospital medicine, and from the legal community, chaplaincy, and our Einstein policy was similarly broad-based. It must be transparent, and it must be based on patient need, prognosis, and likelihood of success, not age, disability, or social worth. And if there is a rationing policy, it applies to everyone. There's no privileged circumvention of it. Those with the means, those with the pointiest elbows, the brother-in-law of the president of the hospital board, otherwise healthy, doesn't get around it. And very important, the doctor caring for the patient is not the rationing agent. The doctor caring for the patient is always the agent of the patient, not of the system. The most relevant issues for rationing during the pandemic have been ICU beds, ventilators, and certain scarce drugs. Some alternatives to rationing going forward would be preventing the need to resort to it, which means compliance with masks, meticulous hand hygiene, social distancing, and stay-in-place protocols. If rationing is necessary, it should not be age, disability, or social worth determined. Some would think that during a pandemic, we have to suspend our basic ethical principles, but that couldn't be further from the truth. There's not a time where adherence to basic principles is more necessary than during a public health emergency, such as that in which we currently find ourselves. And we still want to adhere to the principles of not harming our patients. We should not do what will not benefit our patients. We have to respect the rights of patients as persons, including the right to refuse treatment. We have to observe justice, which is equity, treating patients as equal based on their common humanity. Fairness, which means that any allocation decisions have to be transparent, objective, reasonable, and apply to everyone. And recognize that if someone is sick, we all suffer as a community. Fortitude is not a principle, but it's a virtue. It's a mean between recklessness and cowardice. There's no expectation to take unreasonable risks. No one should rush into a room to resuscitate a patient not wearing proper protective equipment. But there is something in the nobility of the profession that requires us to take acceptable risks. We've had a recurring thing at our hospital where the word gets out, I don't know how, that CPR is not offered to COVID patients who suffer a cardiac arrest. And we have to put the pin back in that grenade about every 2 to 3 weeks. There's a history of less than honorable compliance with fortitude early on during the HIV era, where physicians and other healthcare professionals refused to treat HIV patients. During the bubonic plague in England in the 17th century, the first people to get out of town were the doctors. We want to maximize lives saved and life years saved, and focus our critical care resources on those patients who realistically can survive. There are some objective formulae. I'm not going to go through them, but just mention them. Apache 2, acute physiology assessment and chronic health evaluation. SOFA, which is sequential organ failure assessment, and PELLAD 2 is a pediatric one about which I don't know much. These are scored like golf rather than like baseball. So the higher points people get for these, the less likely they are to benefit from critical care or ventilator treatment. And it involves a bunch of composite things, including pre-existing conditions, age, although age is not an absolute, and then some clinical and laboratory measurements. And these things can be reduced to a number, and the lower the number, the more eligible someone is to receive scarce resources. In Pennsylvania, we are a pro-life state. There are lower points assigned for pregnant women. So pregnant women will have a lower score and will move up in the eligibility criteria. If a patient is not likely to survive to discharge, a different treatment plan is developed. Those who, and you know, who should we really probably not consider for critical care intervention? People who have terminal illnesses, cancer patients who are not candidates for radiation therapy, chemotherapy, or surgery, people with end-stage heart failure or COPD, end-stage dementia, not mild, end-stage neuromuscular diseases, people with severe burns or trauma who have had failed or multiple recurrent CPR attempts, those with advanced liver disease who are not candidates for transplantation, those who have multiple organ system failure. A different plan should be developed for them. But irrespective of what's recommended, the patient or the patient's decision maker still should be informed of the decision to not proceed with ventilator or critical care and have a right to appeal. If a patient will not receive ICU level treatment, they still should receive competent, comprehensive, state-of-the-art care, vigorous palliation, comfort measures, standard care, psychosocial, spiritual support. Dan Silmasi is a very distinguished physician ethicist, and the way he puts it is that some treatments are not worthwhile, but every patient is worthwhile. Paul Ramsey is probably a familiar name to those who are in this group who have a connection with Princeton Theological Seminary. He was a moral theologian. He was with Princeton University. I believe he also had a relationship with the seminary. And he wrote voluminously about healthcare ethics. One of the things for which he is most remembered is his mandate, never abandon care. This comes up too often when we're doing ethics consultations where a resident will call me and say, we want to tell the family, we want to withdraw care from the patient. And I always go bonkers with that because I point out Ramsey's dictum, that is, we provide care to the patient until he or she draws their last breath. We may withdraw certain treatments, but care always continues. This is our chance to have a segue to Christian moral theology and how that tells us something about response to the current pandemic. Christian moral theology is grounded in the healing narratives of Jesus. It entails solicitude for the sick. And if people think that's always been the case, think again. At the time of Jesus, there was a contempt and distaste and odiousness associated with sickness. And the fact that Jesus actually physically touched people with, well, all the conditions with which he did was not standard modus operandi. Healing in God's name. And related to that is all of the Christian healthcare systems and hospitals that have developed throughout history. And frequently care provided without regard to ability to pay. SCRIBONIUS LARGUS is a figure who does not get the recognition that he deserves. The early Christian community was part of the Roman Empire, sorry. And he was a physician to Emperor Claudius of I, Claudius, Robert Graves' Masterpiece Theater fame. He had a large compendium of various potions and medications, which were largely worthless. But he was a groundbreaking figure in care of patients, because he wrote so much about the solicitude for the sick, which included misericordia, which is a term for mercy, and humanitas, which is humanity. And unlike the Hippocratic tradition, caring for friend and foe alike, Hippocrates could not get his mind around the idea that one would take care of one's enemies. Hippocrates made enormous contributions to early medicine and medical ethics, but it was less focused on the patient and more on protecting the good name and reputation of physicians, and also what was good for the business of physicians. Moving through history, Cyprian of Carthage, during the 3rd century of the Common Era. During that time, a horrific pandemic swept across northern Africa. It's not clear what it was, but epidemiologists and medical historians think that it was something akin to modern day Ebola. Cyprian had grown up in Carthage. He was from a wealthy family. He was something of a bon vivant, but showed an aptitude for rhetoric and became a convert to Christianity and became the Bishop of Carthage. And during the pandemic, this is what he had to say about how Christians should respond to the pandemic. And further, beloved brethren, what is it? What a great thing is it? How pertinent, how necessary that pestilence and plague, which seem horrible and deadly, searches out the righteousness in each one and examines the minds of the human race to see whether they who are in health tend the sick, whether relations affectionately love their kindred, whether masters pity their languishing servants, whether physicians do not forsake their beseeching patients. Cyprian came to a bad end at the sharp end of a Roman sword, but he was an important figure in Christian moral theology relating to health. Moving ahead a bit, Catherine of Sienna, a middle-aged mystic, was very concerned for caring for people during the Black Death, the bubonic plague of the 14th century. She thought of everyone as her family. She wasn't a great epidemiologist or public health expert. Among the things they did was to bring plague patients into their homes without any kind of hygienic measures with bad outcomes. John Calvin, if you look at this picture, you get the idea why Presbyterians are sometimes considered a little bit fun avoidant. Calvin wrote voluminously, and he had a very practical side to him as well. He believed in visitation of the sick, even during plagues and pandemics, was an early proponent of hospitalists, where patients who were sick or dying could be cared for in a congregate setting. And he was interested in medications and medicine, in part because he suffered from ill health through most of his life. Getting to more contemporary times, Bonhoeffer wrote that even where there is the smallest possibility of allowing the other to stay alive, then destruction of this life would be arbitrary killing and murder. I don't want to get inside the head of someone who's a personal hero, as is Bonhoeffer and one of the great theologians of the 20th century, but I think I would like to have a conversation with him and walk him through the ICU, where sometimes there appears to be the temptation to treat to the bitter end. World religions fill a gap in our being which cannot be filled by science, technology, or art alone, because that place is meant to be filled with an irreplaceable love, compassion, and kindness, which reminds us of the real essence of humanity. I have to mention there's a dark side of the religious response. I saw a paper in a public health journal within the past couple of weeks that surveyed some Christian communities and found that there was a belief among some that things like mask mandates, prohibition of public worship, things like that demonstrated a distrust of God's ability to intervene and were an imposition on the freedom of worshipers. The church's digital presence requires, what has the pandemic done to the church in terms of worship, education, and care? Well, here we are at a Zoom meeting instead of physically gathered. What has the church done for the pandemic? Well, support for those who have lost jobs, businesses, address new problems such as increased domestic violence, substance use, bereavement, fellowship opportunities such as we have this morning, serving the poor, the sick, the marginalized, the otherwise disadvantaged. Our denomination and the World Council of Churches and another combined group of the World Council of Churches and the Catholic Church has some interesting web resources to which I would refer you. I think Brian has posted these on the Older Adults website. Protestant denominations are typically identified as problem solvers and very good at transactional kinds of things related to health and healing. There are extensive hospital systems which bear the names of mainline Protestant denominations. Catholic social teaching tends to be more conceptual, and Catholic social teaching rests upon these 7 pillars: the life and dignity of the human person. We may have some disagreements with them about reproductive things, but this says a lot about the obligation to provide health care to those created in God's image. The call to family, community, and participation, that persons are sacred, but they're also social, that we all have rights and responsibilities to one another and to society. The preferential option for the poor, that there is a Christian obligation to care for the poor simply because they're poor. The dignity of work and rights of workers. This has really come into focus with observations about disparate compensation for those who work in non-skilled healthcare, such as those who clean patient rooms, deliver food to patients. Solidarity, that we are one human family, or put differently, we're all in this together, and care for God's creation, the environmental stewardship. These are things worth considering, even though they're from a different faith tradition than ours. And I would point out that this country's most prominent Catholic citizen, the new president of the United States, has fully internalized these. If you listen to him talk, and he talks a lot, and read some of the things he's written, these principles really animate him. And it's not a bad place to be with our thinking. So in summary, what we want to do is to maximize the number of patients who can be saved, and also years of life as a tiebreaker. Protect our resources, such as testing, ventilators, ICU beds, make sure that healthcare workers are protected so that they can continue to care for sick persons. Recommendations should be based on science, including for things like distribution of vaccine, protect those engaged in research and vaccine development, and no preference for COVID patients over those with other emergency medical needs. So no COVID exceptionalism. People with heart attacks, with major trauma, who have bleeding emergencies, other kinds of things are equally placed in their need. These have been challenging times. This is our dog, Teddy, looking out wistfully, missing our friends and kids and grandkids. I miss doing the fun stuff. Those of you who know me know my obsession with trolley cars, such as on the left side, the old cars that ran between 69th Street Terminal and Westchester along Westchester Pike until 1954, and photo I took at the Pennsylvania Trolley Museum a couple of years back. State-of-the-art trolleys such as I got to see and ride and photograph in Porto, Portugal in September of 2019. I keep myself entertained building and operating model trolleys, and with the work that I do, with the patients that I see, and the ethics things that I get to evaluate. So I'm staying safe and fulfilled. I hope all of you are safe, fulfilled until we can be physically together again. Thank you for your attention. I'm sorry I went over time, but be happy to respond to any questions.
Thank you, Rich. Thank you so much for that detailed, thorough, clearly really wonderful presentation. We have quite a few questions. I'm going to take about maybe 8 minutes or so to get us to about 11:15. So we'll take a few questions for that time. And I'm going to try to kind of bundle some of the questions together that we got. So there were some questions that came up regarding the vaccine rollout and this step-by-step 1A, 1B, 1C, and group 2. I'll offer kind of two questions together. One of them was that a person asked, my understanding is that Pennsylvania is now including those 65 and older in group 1A. And then with that kind of additional question, how quickly do you expect we'll move through these groups? When might we get to 1C and group 2? And will there be sufficient supply to get there?
Okay. Can you see me on the screen?
Yes.
I'm not sure as far as it. Yes, there is some blending of the 1B, 1C, but it's easy to say. But what we found out last week is there is going to be a very significant supply problem for at least the next 2 weeks. And probably 3 weeks. Pennsylvania is receiving between 38,000 and 50,000 doses per week, which is nowhere near enough to meet the need. I believe some of the retail pharmacies are starting to offer appointments, but someone's calling me. Okay, I'll get to that. But the rollout it's still a work in progress. I wish I could give you an answer on that. The hope is that there will be a pretty active vaccine program by mid-February, once we get past group 1A.
Thank you.
But that's an aspiration.
Earlier in your presentation, you made the point that children carry a higher viral load of the virus than acute cases with older individuals. Does that mean they are more likely to transmit COVID, and are older people more likely to catch COVID from them?
Yes.
Okay.
Yes.
And then a follow-up to that, as far as in children, you mentioned again that you mentioned about pregnant women and risk. How about nursing mothers and possible transmission to babies?
I haven't seen any data about that, so I don't know, and I'd rather tell you I don't know than make something up.
Okay, I agree with that. Another question here about the doses themselves. Have pharmaceutical companies considered pre-filled, single-dose syringes that could help speed up the distribution? Obviously, right now it says currently only multi-dose vials are available. How long in advance can the syringes be pre-filled and stored for large clinic distribution, or must each dose be drawn at the time right before giving?
Well, probably the most widely used one right now is the Pfizer, and because of the requirement for ultra cold storage, the logistics of storing multiple filled syringes might overwhelm the capacity for that, I think.
Another question related to the actual giving of the vaccine. Is there a reason to be concerned if there is a delay beyond the time tested for the second dose, as the media is saying may happen?
Well, would be an uncharted territory there because, the regimens have been developed for a reason because that's what's been tested. So it may be as effective, but that has not been demonstrated.
Okay. You mentioned earlier that the state of Pennsylvania has a plan and then Philadelphia County has a separate plan. Have they developed specific plans? You mentioned this group of homeless, migrant, psychiatric, other people with unstable lifestyles. Is there a separate plan that's made to address those individuals?
The plan, and this was the thing that I was most vocal about with it, is that I don't think that people with unstable lifestyles can be counted upon to return for a second dose. So I think they should be prioritized to receive a single dose if it's available. And yeah, that's all I can say about that. Yeah.
Okay. And it looks like about 2 more questions here. First, if someone has a dermatology issue, is one treatment suggested over other treatments?
What kind of an issue?
It says dermatology. Janet White, if you asked the question to the whole group, if you want to.
Dermatology. Yeah, Janet, can you unmute yourself and
Yes, dermatology.
Oh, sorry.
Sorry.
have not seen anything about that, Janet. Yeah.
Okay.
Yeah. There's not been any significant skin reactions described with it. Anecdotally, when I received my first dose, I had a sore arm for about 18 hours, and that was it.
Thank you.
Yeah.
And the final question is kind of a combination of 2 questions here. It says California right now is calling for volunteers to help administer the vaccine. So is the same true in Pennsylvania? And then kind of bigger than that, how can we as private citizens help with the vaccine? How can we help ensure that underserved groups receive it?
Well, we first have to have a distribution plan where they're going to receive it. And then if those sites need volunteers, I think the word will get out, like for, retired nurses, healthcare professionals to work as volunteers in administration sites. We really need a little more clarity as to where it's going to be. If you're going to get it at Rite Aid, I don't know if they're going to hire part-time people, or I think they have a certain limited number of people just because of physical isolation that they will take by appointment in a pharmacy in a given day, because there are some logistics there. You need space for people to be physically separated. People have to, after they receive the vaccine, sit for 15 minutes to be sure they don't have an adverse reaction. So think about the pharmacies you go into. It could get pretty crowded pretty quickly if you're going to have chairs around for people to sit in. But once there is a distribution plan, it may require some increased people for administering the vaccines. Right now, people are describing just chaos trying to schedule appointments. And the big thing is the bottleneck of receiving vaccine. As I said, hopefully by sometime in mid-February, there will be much more availability of doses to administer.
And Rich, do you think that as far as the plan itself, we just have a comment here that I've heard from a number of people that right now, the process to sign up to even be part of the vaccine list, so to speak, is fully online. It doesn't have a phone number, it doesn't have a paper aspect to it. Do you know of any process in place to ensure that people that don't have access to internet, people that are not comfortable using the internet, is in place to make that happen?
That's a problem. Well, the thing, they can go to their retail pharmacies and get on a list once they have a list. The Rite Aids apparently have a list. CVS does not. I don't know what the story is at Walgreens. And most of there aren't that many private independent pharmacies around any longer. But most of them don't have like a minute clinic or something like that.
Gotcha. Gotcha. Well, thank you, Rich. I'm gonna, in just a second, turn it over to Pam again, but I just want to say thank you immensely for all the time you put into this. Very grateful for you and for your service to our community and to our church. I'm going to go ahead, you mentioned it earlier, I'll go ahead here and put in the chat the link to the church's page we've put together for COVID-19 resources. And with that, I'll turn it back to Pam.
Thanks, Brian. Rich, I'm just going to echo what Brian said. Thank you so, so much for all the information and your perspective about COVID treatment, prevention, and the ethics surrounding them all. I know we're all grateful for the work you're doing and that you put this together for us this morning. Thanks again. And everybody, thank you for joining us, and please stay well.
Okay.